Okay, welcome to the Spine Conference. Today's discussion is going to be a case that rolled through the office that I want to share. So this is a 25-year-old man with the chief complaint of low back pain for 6 weeks. It started after he was lifting weights. He's a very robust weightlifter, and he was doing squats at the time. And since then, he's had low back pain. On physical exam, he's a very strong young man, 6 feet tall, 200 pounds. He used to be a football player, and he really enjoys lifting weights. It's a big part of his life. It gives him a lot of enjoyment, and that's his main form of exercise. And his office job is some type of a clerical position. Doesn't require any physical activity. And on exam, he's just stiff, basically, on his lower back. He has no pain at night, no weight loss, no weakness, no constitutional signs or symptoms like a tumor or something. So he has an X-ray. What do you think of the X-rays, Aaron? Come a little closer to the microphone. Okay, so decreased disc height L5S1, strong bones, right? So before he saw me, he got an MRI from his primary care physician. But what would you do, Kirsten, what would you do with a 25-year-old weightlifter with low back pain?
As far as an evaluation or treatment? For physical therapy?
Let's go with treatment. Yeah, for physical therapy.
I mean, if he has, I'm guessing, being a weightlifter, he probably has extremely tight muscles. He probably doesn't ever stretch because everyone who comes into our door does that, but probably also working more of their core stability muscles, transverse abdominis, multifidus.
How do you do that?
You have to activate. It's like more of a, as opposed to training the global muscles like lats, which most weightlifters are training, we focus more on transverse abdominis contractions with adding movement in order to create stability.
How do I do that? My back hurts. I want to work on my transverse abdominis.
So we would teach them the most basic contraction, which is laying in supine hook lying. And you would
lay supine?
What?
Lay supine?
Yep.
And do what?
Bend your knees.
Lift your knees up?
Bend them. Yep, feet on the floor or table. And then you would teach them how to contract their transverse abdominis. Most people want to contract like globally, like their rectus abdominis, but you kind of teach them that it's almost like bearing down, like you want to cut off urine flow. Like you can also equate it to a Kegel exercise sometimes to try to isolate the muscle a little bit more as opposed to activating the whole rectus abdominis muscle.
Okay. Okay, so he comes in with an MRI. So what do you see on the end? This is sagittal cuts, T2 weighted images. Aaron?
Well, on the left side, pretty normal. L4, L5, L5S1, and kind of decreased signal. Maybe a small L5S1.
So L4, L5, L5S1. So you can show everybody as a decreased signal in the disc spaces, right? What does that mean? Right, less water content of the discs. And how about on the right?
On the right side, there's this very prominent bright white fluid, like water film, circular structure in the L5.
Right on T2. And is it small, large? I like to give numbers because then discrete, the percentage of the body.
Maybe 40%.
Yeah, 40% of the body on that view, right?
Correct.
And posterior, and if within the body. And the other most important thing is, well, that's good for now. Okay, how about now? These are what?
T1.
Yeah, T1.
T1 again on the left side. You don't really see that on the right one. It's like the third.
Okay. Same as CSF, right? Same as the spinal fluid posteriorly. So this is show everybody the anatomy here.
You have your here and here, posterior spinal process, and you have nerve roots actually.
The foramina. Is this abnormal or is this normal?
This is normal.
Okay, it's a normal level. So what do you see here?
Same thing, that in the spinal canal is still nice and open. You can still see the nerve roots.
See the little dots, little nerve roots. You see them very well. Mm-hmm. Okay, so there's a thing in the bone that lights up that's abnormal. Now describe the shape of it. Is it an irregular shape?
Yeah,
it's very regular. Well defined. The boundaries are discrete, or are they permeating through the bone? What's it like? The boundary of this problem, like very sharp and discrete, right?
Yeah.
Very like geographic. Like you could take a line and go all the way around it and know exactly where all the borders are.
Right.
So it's called we call it geographic. Like if you could, it's like a map. You could like go over the border of a state. You know, you go to the border of a state, you can tell exactly where it is. Same as the tumor.
Right.
So that means that it's probably a benign tumor. So to fully evaluate spinal tumors well and see the reaction of the bone to the tumor and the tumor's reaction to the bone, a CAT scan is very helpful to look at the bones. So this is a CAT scan, same view as this, but now a CAT scan. So what do you think of the borders here?
Still well defined.
Well, very discrete, well-defined borders, geographic. And how about the response of the bone to the tumor? Is the bone responding to it?
It doesn't look like it's the only slight abnormality. Right here doesn't look like it's
Mm-hmm. Oops. Yeah, right there, maybe. Okay, so this is a soft tissue, kind of the same, right?
Same.
Yeah. How about the coronal sections?
Same.
Kind of the same. It looks bigger on the coronal, so it's kind of interesting. It goes up and down a lot, doesn't it?
Right.
So it's yeah. On this view, it goes up and down a lot, so it's kind of like a rectangular shape, sort of, that goes all the way up and down the bone. So this we live in a world where things have repercussions and there's connections, and it's a complicated world, okay? So the report said, the doctor read this, said you need a bone scan. And so I always get, whatever radiologist requests something, I get it. But this bone scan is helpful because it helps you with understand what this thing is. So, and the other thing is, when I order a bone scan, I always get a bone scan of the whole body, because for me it's a freebie. because it doesn't cost them any more money to do the whole body, and then I can make sure there's no cancer anywhere in the entire body. So it's a nice screen, but also looking at this lesion. So this is the images, the delayed images, and just so you know, there's no uptake here. And then I did a SPECT imaging, which is kind of like sections, like a CAT scan sections of the spine, and it does not light up anywhere. And then they do the coronal sections. And here are all the individual sections, the axial sections. And the L5 body is like number 22, number 23, number 21, around there. It doesn't light up. You would see like a really sharp, if it was a cancer or a tumor or a fracture or an infection, you would see a very sharp, discrete focus of light. And this is the whole body. I like to get the whole body because it's a screen, and why not? Because we're worried about cancer. So I can tell from this that he's a weightlifter. How can you? Do you know? Tony? What do all weightlifters? You're a weightlifter, right? Used to be a weightlifter, Tony. What do all weightlifters get? Don't say medical, just stuff. What do weightlifters complain about? The shoulders hurt, right? And the shoulders from impingement. So you see how the AC joints light up? So you can tell he's a weightlifter. All weightlifters have like a little bit of shoulder pain just because they stress their shoulders when they lift weights. I don't know what that's. I don't think that's anything. Yeah, I see that the anterior iliac spine and posterior iliac spine light up. I don't know what that is. Maybe because he does squats and he really stresses those. Yeah, he does do a lot of squats. And the bladder, you see the bladder lights up just because he's urinating out the dye. So, okay. So what is it, Aaron? What is this? What is it? Huh? It's a bone cyst. Okay. So 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 is this so? If you see a lesion in a bone, the first thing that should go through your mind is met. When I was a resident, this is what we learned: myeloma, lymphoma, metastasis. So whenever you see a lesion in a bone, that should be the first thing that goes through your mind for an adult, anyway. So I knew it was very, very unlikely that was those things. First of all, the one on the left is what a metastasis looks like. So it's usually multiple bones. It's usually not really sharp. It invades the bones. Even you can see L5 that could be possibly a solitary metastatic lesion, but it's very unlikely. Usually metastatic lesions present with multiple areas, but it's possible. It's possible that it could be a very early first one that we somehow caught it. On the right, bottom right is a lymphoma case. Usually the lymphoma spreads across the bone very quickly and encapsulates the whole bone. But it could be a very early one, but unlikely. Usually that's how they present. Same as myeloma. Usually they go through most of the bone, but it could be a solitary plasmacytoma, which is a really small focus of like myeloma-kind cells. It's possible, but it's very rare. So it's probably a benign tumor. It's probably not those cancer tumors. So the differential diagnosis is an aneurysmal bone cyst. We'll go over what that is. A giant cell tumor is possible. Chondroblastoma usually looks like cartilage. It could be an osteoblastoma, but usually osteoblastomas have both a sclerotic and lytic portion. It's very unlikely fibrous dysplasia. It's very unlikely these other things. So it's probably, yeah. Aneurysmal bone cyst lights up. Osteoblastoma lights up. I'm not sure about the other two. So it's probably a simple bone cyst or a unicameral bone cyst. Unicameral just means one chamber, which differentiates it from aneurysmal bone cyst, which I'll show you has multiple chambers. So a simple bone cyst, or also called unicameral bone cyst, it's usually kids, and it's usually the distal radius and the proximal femur. So 85% of these cases of unicameral bone cysts are between the ages of 0 and 20. It's usually when the children are still growing, and they usually go away after skeletal maturity. And 2/3 present as fractures, and in adults it can present in the ilium and the calcaneus. But most of the cases, the vast majority of cases, are proximal femur, 50 to 60% of the proximal femur, and 25%. I'm sorry. 50 to 60% proximal humerus, 25% proximal femur, and very common is distal radius, and you can get them proximal tibia. So it's usually the extremities. It's very rare for it to be in the spine. It was first described by Virchow, who was a German pathologist. So there's three theories for what these things are. It's either venous obstruction or congestion, and I'll go over that. Encapsulation of a metaphyseal hemorrhage, so maybe you hemorrhage into the bone and then the bone gets degraded from the inflammatory response, or maybe microtrauma and there's an inflammatory response and creates a cyst. I think that's unlikely. So what is sludging of the metaphyseal arteries? So in a kid, the arteries go into the physis to give it blood supply to grow, and then it becomes venous venous flow, and it goes back to the heart. And at that junction, at the physis, the metaphysis next to the physis, where it goes from arterial to venous, the blood sludges. It's basically an area like of high flow sort of, and there aren't a lot of phagocytic cells there for some reason. So this is an area that gets problems in kids, and it's usually infection. Usually kids can get osteomyelitis of their bones at that area because of this process, the disease process. And some people think that this same disease process somehow is causing the cysts, these unicameral bone cysts, because you never see them in adults in the wrist and the proximal femur, never. So this is where the physis is in the distal radius, and the physis is the area that grows. So the children grow in their spines too. So show the black line is the physis in the spine. Show it, Aaron. So there's one in the pedicle. And then there's all the way around the bone, there's a physis. And on the side cut, you see it's on the growth plate, on the top and bottom, the end plates, the end of the vertebral body, the vertebral body end plates, Aaron. Yeah. So that's where the kids grow. So just so you know what it looks like, this is a unicameral bone cyst of a calcaneus, and this is a unicameral bone cyst of an ilium. You can see it's just one chamber. Now, if you scoop these things out, what does it look like? The inside is usually clear fluid, and there's a brown fibrous membrane. And the membrane has spindle cells, sometimes some giant cells. There's a lot of connective tissue, and the surrounding bone can be irregular. So this is what a cyst looks like microscopically. This is a case of aneurysmal bone cyst, so you know the difference. Aneurysmal bone cyst is common in the spine. It's a more destructive process usually, and it has multiple segments. You see there's like multiple holes sort of. And if you get an MRI of this, it looks like this. You see how it's kind of weird. There's all these different fluid levels and all these different like chambers sort of. And that's why unicameral bone cyst is called unicameral. It's just one chamber. It's just simple. And aneurysmal bone cyst has many little pockets. So this is what aneurysmal bone cyst looks like. And there are different disease processes. Unicameral bone cyst usually just goes away with almost anything. Aneurysmal bone cyst is a more aggressive tumor. You have to resect it more aggressively, and it can come back. So it's a different disease process. So how do you differentiate simple bone cyst from aneurysmal bone cyst? We went over the fluid levels, and also the ABC lights up on the bone scan. How do you differentiate from a chondroma? Chondromas, you can see like calcification from the calcium inside. The MRI looks different. The MRI doesn't look like fluid, it looks like calcium. And you can tell in the x-ray. How do you differentiate from fibrous dysplasia? Fibrous dysplasia has a very typical look. It's called a ground glass, but it can also be clear. I'll show you a case of that. How do you differentiate from giant cell tumor? I think it's kind of difficult to differentiate it. So this is a case report from 2004 of a simple bone cyst in the pedicle of the lumbar spine from Japan. I wanted to show it to you guys. Show Aaron, you see the arrows. So there's a lucency in the pedicle. This is an adult. And you can see the x-ray, and then you can see the CT where it's just one chamber, but it's interesting. It fills the whole pedicle and goes into the vertebral body. And what they did is they inserted cement into it. I guess it was symptomatic. That's why they treated it. That's kind of easy because it's right in the pedicle. And the path showed the cyst wall had a couple of osteoclasts and irregular bone. So what's the treatment for these things? First of all, if the patient has no symptoms at all, do nothing. They usually go away. And this guy is unusual. He's an adult. I don't think it's a cyst that's a problem. I think it's the discs that are giving him this pain. And since no adults really, it's very rare as an adult, this whole thing will probably just go away. But the treatments are just, you have to, basically everything kind of works. There's a lot of different options. You can insert autologous bone marrow into it. You can insert demineralized bone matrix. You can just stick steroids into it. And some people put ethanol into it to kill the lining of the cells. Another option is the calcium sulfate pellets. You can just basically debride it and then stick pellets in there. And the nice thing about the pellets is you can see that it heals. So the key prognostic indicators for success is age. So the very young kids have a very common tendency to recur 60% successful. And the older the kid is, 90% success. So probably it's like it goes away by itself probably, when they become mature. And this is just if you're curious, when do the physes close? It's a whole list of all the different physes and when they close. And you see the sacrum is the oldest one to close. It closes like 30 years old. Yeah. Yeah. The most common one is distal radius, and distal radius closes from, 13 to 22. So the distal radius can stay open. That's why a lot of boys and girls present with distal radius fractures in their teenage years, playing soccer and whatnot, wrestling, because that's when they start to close, and that's when the physis is at its weakest. I think it's like 20s, like 25, 23, 24, 25, I think. Yeah, that's the lower jaw is old, and the other one that's really old is the proximal clavicle. That's why a lot of boy wrestlers dislocate that. So any questions so far? Okay, so here's another case report from Bologna, Italy, of a 16-year-old girl with a 2-year history of low back pain. And the x-rays, you can see like, yeah, at L4 there's a problem. And this one looks remarkably the same as our guy, isn't it? In the CAT scan and the MRI scan, except it's L4. And it looks exactly like our guy. It's kind of amazing how similar it is. So this case was symptomatic, and the child was complaining of pain, so the doctors inserted a 14-gauge needle into the bone and inserted steroids. Oops. And here is post-op. You can see the needle track. And the patient healed. So in that article, they stated there's 5 cases of UBC in the spine that they know in the literature. So it's a very rare. We had one in Harford County, so it can't be that rare. But usually people just don't. They probably see it and they don't think it's anything that's benign. Just throw it in the trash and not worry about it.
So will we heal? Or will it always be
Yeah,
there?
I mean, it should heal. If it's the same, I don't know. I mean,
Do you think it's traumatic from his lifting?
I don't think so. I think he's just bad luck. He's just a kid who got it, and it's probably going to go away. It's easy for me to stick a needle in it with steroids, but I think it'll probably just all go away.
Something that you would follow? If it's that rare?
No, it's a benign process. It doesn't get worse. It's not like aneurysmal bone cyst, which is aggressive. This is benign. So he needs somebody like Kirsten to work him over, work on his.
Well, one of the things you didn't share is
Yeah, it's
he
cool.
had a maternal uncle who died from bone cancer.
Right,
So his family was really concerned.
right. But we did the workup,
Right.
so we did everything. It's not cancer. It's not. It's a UBC. And we did a literature. It looks exactly like the UBC in the literature, so I'm pretty sure it's a UBC. It's a rare case, though. So any other questions about civil bone cyst?
Would you ever like do a needle loop and like test the fluid or anything like that?
Well, if I do a treatment, I would, but I'm not going to stick a needle in someone's spine unless I'm going to like treat it. Just for diagnosis, I wouldn't.
And if you're gonna treat it, would you take out the fluid that's in there
Yeah.
before you would
I would.
aspirate it?
Yeah, I would aspirate it. I'd probably aspirate it, irrigate it to get any fluid that's in there out, because maybe the prostaglandins or maybe the inflammatory things inside of it's causing it. And then I'd probably stick bone paste if I can find it. I don't know do we have bone paste in the United States? Yeah.
Like DBM?
Yeah. Oh no, like yeah, I'll probably do DBM.
You could do like a DBM.
Yeah. I'll probably do DBM. And a young guy, so he can all heal up to go back. So now we don't have to worry about him fracturing his spine, so he can go back to his weightlifting without problems.
Is there concern that
I don't think so. It's not that big.
40%?
Yeah.
Height?
Yeah, but usually I don't think so. These are slow processes, so the bone reacts to it and gets stronger around it. Although it didn't look strong in the CAT scan, but I don't think so. I don't think he's going to break that. You can get some pretty big hemangiomas that don't break in a strong guy. I did tell him to stop squatting and powerlifting just because I don't like that for the discs. So I told him to stop powerlifting.
Right.
Just lift, light weights, like body weight weights. Just because that's my opinion, because he doesn't need to do it. But he's still in the high school mentality that the lift is the highest weight possible. Yeah, max out. What's your max? What's your max?
Because he was warming up with 200 pounds to get up to his 400.
Yeah. So it's fun. It's part of the fun of weight lifts. It's part of the fun of lifting weights is lifting a lot of weights. But then when you get older, you have to work. You have responsibilities, and you also want to keep lifting. So, you probably should learn that now. So what else? Any other comment? Kirsten, you have any comments? Physical therapy perspective?
I mean, the thing about physical therapy, we always explain to patients is that it's not going to change what's going on with the bone. You know, we just have to strengthen everything around it, stretch everything around it, teach better body mechanics and posture. A lot of weightlifters aren't going to listen if you tell them to stop powerlifting.
Right. Weightlifters never listen, and the
No.
other people who never listen are marathon runners. They never listen. They're very, very hard to change their behaviors. They're very dedicated to that sport. Marathon runners would rather die than stop running marathons.
Mhm.
All right. Any other questions or comments? All right.